and today we are going to talk about nephrology. Nephrology is almost the same. You can say one part is same as we will be having the two sessions. First session is all about the theory. Today we are going to talk about, and the second session will be all about your investigations of which you are going to have in your renal system. So first part theory is almost all just like your part one, which you have already read about in your FOB and TAS. And the investigations are a bit difficult and the tricky. So we will be covering those in the next session. Today, we are going to talk about the theory, a little bit more about it and how we are going to apply that in our scenarios. So let's just start with it. First of all, we are going to talk about our nephrotic syndrome. Two to three, you can say the topics, nephrotic, and then we have the acute glomerulonephritis, then we have our tubular disorders, and we have our UTI. These are the most important topics, and these are the all topics they are going to talk about in one or in another way. So that's why especially your glomerulonephritis and your UTI, these are very, very important to understand and to make differentiation between different types of the glomerulonephritis and how we are going to target our UTI. So let's just start with our nephrotic syndrome. Let's just dig into it and see what we have here. So nephrotic syndrome, there is nothing new. I will just say that it's just I have summarized all of these things with a little differentiating point that how we are going to diagnose different things in the different scenarios and how we are going to apply this or theoretical knowledge into our scenarios. So nephrotic syndrome, you know that how we say that this is going to be the nephrotic, we know we have the 4 criteria for that. There should be edema. Along with that, we are going to have the hypoalbuminemia and your plasma albumin should be less than 2.5 gram a liter. Then you have the heavy proteinuria, which is going to be defined by your dipstick should be 3 plus or more. Or you can have the urinary proteins, which should be greater than 40 milligram per meter square per hour. Or early morning protein to creatinine ratio should be greater than 200 milligram millimole. All of these are called as the nephrotic range proteinuria. You can have any one of these criteria, like you can either have this urine 3 plus, or you can either just go for the urinary protein quantification or by the early morning protein to creatinine ratio. All of these are showing you that these are the ranges which are, if they are available, then we are going to say this is your nephrotic range proteinuria. Then we need to have the hypercholesterolemia. So we have the 4 criteria of edema, hypoalbuminemia, nephrotic range proteinuria, and the hypercholesterolemia. If this criteria is going to be fulfilled, then we are going to say that this is a case of a nephrotic syndrome. Then how we are going to classify this nephrotic syndrome? First of all, you know that it is going to be the primary glomerular disease, which is also known as the idiopathic one. And second is your secondary disease because of some underlying other problem. So in among our primary glomerular disease, number one, we have the minimal change disease, which you all know is the most common one in your pediatric population. About 80 to 90% of your nephrotic syndrome is going to be your minimal change disease. Then we have membranoproliferative glomerulonephritis, focal segmental glomerulosclerosis, and the membranous nephropathy. Remember that I have just written these just for the sake of your, you can say, memorization. Because when they give you scenario of, we know that in the minimal change disease, we have a typical nephrotic syndrome, and other thing we have atypical nephrotic syndrome. We will talk about in a bit in the next slides. So minimal change disease is your typical one, nephrotic syndrome. And that is if you got a scenario of a typical nephrotic syndrome, all the features which are fitting in your typical one, then that is going to be your minimal change disease. But when we are going to have the features of atypical nephrotic syndrome, then it can be anything. It can be membranoproliferative, it can be focal segmental, it can be membranous nephropathy or something else. Rapidly progressive glomerulonephritis, it can be anyone. Then how you are going to differentiate all of these on the basis of just clinical scenario, that this is a case of either focal segmental or either membranoproliferative. Remember, one striking and the differentiating point which they give you in the exam is when you got the low complement levels and all the features are of atypical nephrotic syndrome, that is going to be your membranoproliferative glomerulonephritis. But when you are going to have all the complement levels are going to be the normal with atypical nephrotic syndrome, then that is most likely your focal segmental. we are just excluding the secondary diseases here. We are just talking about the primary glomerular disease. So we are going to have 4 main primary glomerular disease for our nephrotic syndrome. Then we can have some secondary disease, or it is also called as the non-idiopathic, which is ultimately going to lead to have this nephrotic syndrome. One of them is the very common, also you can say Hinanshu-Purpura, that is your HSP, then SLE. SLE is also very, very important. It led to your lupus nephritis. Then we have some infections like the Hep B, Hep C, and the HIV, which are secondary causes, and they can cause you the nephrotic syndrome. Then some drugs like the penicillamine, NSAIDs, mercury, and the lithium, they can also cause that. Then we have another classification or the type, which is called as a congenital nephrotic syndrome. Dr. Tatiana is asking how will recognize membranous nephropathy. Membranous nephropathy is only going to be can be differentiated on the basis of your renal biopsy finding. Otherwise, you cannot diagnose it on the, you can say, because it is also going to have the normal complement levels. So you cannot differentiate just on the basis of clinical scenario. And that's why they do not give you this scenario also. They usually just give you the minimal change, membranoproliferative, or the focal segmental. Among these are the 3 most common things which they give you in the scenario. And in the secondary diseases, the most common one you need to have is HSP and the SLE. These are the 2 most important which they give you in the different scenarios. And these are the repeated and the repeated one. Did they give biopsy findings? It all depends on them. Sometimes they give you the scenario and then they ask you the skin biopsy finding, but that is also very rare. That is mostly the scenarios of your FOP and TAS. But here they give you, sometimes they give you biopsy findings, but most likely they give you the complement levels, IgA levels, and the renal profile along with that. And the blood pressure is present or not, hematuria, and the proteinuria, all of these. And also they are going to give you those clinical scenario. Dr. Haja is asking how to differentiate between minimal and the focal segmental. I just talked about that. Minimal change is going to be your typical nephrotic syndrome, all the features, and your focal segmental is going to have atypical features. And what these features are, we are going to talk about in a bit. Just hold on. Then we have the congenital nephrotic syndrome, which is basically when it presents in the first 3 months after birth, then we label it as the congenital nephrotic syndrome. What are the different clinical manifestations you can have in that? Obviously, edema, we know that generalized body edema in which starting from head to toe, you can have the periorbital, pedal, sacral, and the scrotal edema. You can have ascites or even the pleural effusion. Because of this pleural effusion, you can have the respiratory symptoms, that is going to be your tachypnea and the recessions or the respiratory distress you can have because of this pleural effusion. And because of the ascites, you can have the abdominal distension, and the patient can present with you diarrhea, vomiting, and looks unwell. Patient is going to have the abdominal distension, and when you go for the clinical examination, there will be shifting dullness, or the your fluid is going to be positive, which is showing you that there is ascites underlying. And sometimes this ascites can get infected, having the bacterial infection, which is called as the spontaneous bacterial peritonitis. In that case, there will be abdominal tenderness, there will be fever, and there will be umbilical flare, or you can say the umbilical redness. Then among the cardiovascular, usually you get the signs of the hypovolemia, but it is difficult to assess due to edema. So you need to assess very carefully for this hypovolemia. You can have the poor peripheral perfusion. Your capillary refill time can be greater than 2 seconds. Your pulse character can be thready. It can be low volume, difficult to palpate. Tachycardia will be there, or upward trend in the pulse rate. And you can also get the muffled heart sounds if there is any underlying pericardial effusion. So all the signs of, you can say, when we have in the severe dehydration or the hypovolemia or the hypotension, you can get all of these, but it becomes sometimes difficult to assess because there is basically edema all over the body. So it becomes difficult to differentiate that how we are going to label it as the hypovolemia or something hypertension, because usually we suspect that in the nephrotic syndrome, patient is going to have the hypertension if it is an atypical syndrome. So this is the clinical features. On the basis of that, you are going to label that whether this is a typical nephrotic syndrome or whether it is atypical nephrotic syndrome. for your first of all, the age when it is falling between the range that is 1 to 11 years, this is called as your atypical this is called typical nephrotic syndrome. When the age is less than 1 year and the age is greater than 11 years, see, then it becomes atypical nephrotic syndrome. Then it comes in the range when you are going to label it your atypical one. Then the renal function test, they are normal in your typical nephrotic syndrome, while you have the elevated creatinine in your atypical nephrotic syndrome. Then what about the hematuria? Hematuria usually it is not present in your typical nephrotic syndrome. It is very rare. It is very rare. Only like 10 to 20% cases in typical one you can get the hematuria, but otherwise it is very rare that you are going to get that in your typical one. Even if it is present, then it will be isolated. It will not be present with all the other features of your atypical nephrotic syndrome. Remember that. But in your atypical nephrotic syndrome, you get this macroscopic hematuria. Hematuria is a feature of itself, you can say pathognomic or the feature of atypical nephrotic syndrome. You just need to remember that we don't have any hematuria in the typical one, and we have the hematuria in the atypical one. Then what about the hypertension? Typical nephrotic syndrome is normotensive. Usually we have the hypovolemia, but when you get the hypertension, that is going to be your atypical nephrotic syndrome. When we are going to have the complement levels, what about that? They are normal in your typical one and they are going to be the low in your atypical nephrotic syndrome. Then response to steroids is 90%, which means very, very good response of steroids in case of atypical nephrotic syndrome, and there will be very poor response to the atypical nephrotic syndrome. What are the common features which we take while categorizing them within the typical or the atypical? It is the age. What is the age? What about the renal function test? What about the hematuria? And what about the hypertension? These four features are the pathognomic to label them as the typical or the atypical. Then among the complement levels, they vary in between different you can say the causes or the different types of the like focal segmental, membranous proliferative or something else, or the lupus nephritis. They vary. Complement levels vary. But just one thing, remember, they are always normal in the typical nephrotic. When they become low, they become decreased, one or another one is decreased, that is going to be into atypical one. And the response to steroids is but these are the main four features on the basis of which we categorize them as the typical or the atypical. Typical is minimal change disease, which is 80 to 90% is the cause of nephrotic syndrome in the pediatric population, while in the atypical one, we have the different categories: focal segmental, rapidly progressive glomerulonephritis, or membranoproliferative, and like lupus nephritis and the other things, even HSP nephritis. So we have the different categories, different types, but typical one is always minimal change and it's going to respond to the steroids. And it is the most common one. Then what are the investigations which we can have in case of nephrotic syndrome? Remember that the femoral blood sampling is contraindicated in the patient of nephrotic syndrome because of the risk of the thrombosis, because it is a, you can say, prothrombotic state. Patient can have the thrombosis at thrombotic events in the different areas of the body. We will talk about that when we are going to talk about the complications of the nephrotic syndrome. So first of all, the urine, the most important one, you will go for the urine dipstick, and it will show you the proteinuria of the greater than 3+, and it can also show you the hematuria also if it is atypical one. Then you can go for the early morning urine to protein, urine protein and the creatinine ratio. And the first morning after admission, its normal value is less than 20 milligram millimole per millimole. And nephrotic range is when it is going to be greater than 200 milligram per millimole. And usually it goes above 600. But if it just becomes greater than 200 milligram, it means that this is your nephrotic range proteinuria, and it will fulfill your one criteria of the nephrotic syndrome. Then if you get the blood or the hematuria on the urine dipstick, then you will go for the urine microscopy. Only if significant hematuria is present, whether it is macroscopic or whether on the urine dipstick. And you will go for the culture only if you are suspecting UTI also along with that. Otherwise, there is no need of the culture. Then after urine, we are going to have some blood investigations. Among that, some are supportive and some of you can say aid in the diagnosis. Full blood count, what it will show you if there is any infection. It will show tell you about the TLC count and which will favor the infection or not. then you can get the high hematocrit. If you get the high hematocrit, it means that there is going to be the intravascular fluid depletion, due to which you are getting this high hematocrit. Just like in the dehydration, we get the high hematocrit. Similarly, in these nephrotic syndrome, we are going to get this intravascular depletion or the hypovolemia, which will be shown if you get this high hematocrit. Then you will get an idea, even though this is not the, you can say, the definitive, but it will give you an idea that what is going on in the body of the patient. Then you can go for the urea, electrolytes, and the creatinine. Obviously, you will see the creatinine, whether it is normal or not, whether it is raised or not. Hypovolemia, tubular plugging, or nephritis, it can be anything. So if it is raised, either it can be just because of the hypovolemia, and once you correct the, you can say, treat the nephrotic syndrome, it is going to resolve. But if it is persistent and there is also no signs of the underlying hypovolemia, then this is your nephritis, which means atypical nephrotic syndrome. And electrolytes, you can also go for that concomitantly just to see if there is any abnormality. Then our most important one is our albumin, which will be less than 2.5 gram deciliter within the nephrotic range. Then we can have the cholesterol, that is going to be the highest. So our cholesterol, hypercholesterolemia, hypoalbuminemia, that will be make you, will add, you can say, fulfill two criteria of your nephrotic syndrome. Then you can go along with that C3 and the C4, which are very also important, because if they are normal, then that will be a typical nephrotic syndrome. And if they are decreased, then you will say that this is your atypical nephrotic syndrome. Then you can go for the Hep B and the C serology only in the case of when you cannot find any obvious cause of the, you can say, this nephrotic syndrome, or if your nephrotic syndrome is not responding to the steroids and you are suspecting some other secondary pathology, then you will go for that. And the varicella zoster immune status, it is now recommended by the NICE guidelines to have these immune status at baseline. It means that whenever some patient with the suspicion of the nephrotic syndrome is admitted to the hospital and you make a diagnosis on the basis of the investigation and the clinical condition, then you have to check at that moment also for this varicella zoster immune status, whether the patient is having negative antibodies or the positive. If the patient is positive, then there's no need to worry. But if the patient is negative, then you have to immunize the patient against the varicella zoster immunization. Again, varicella zoster. So this is very important. That's they recommend that now at admission you need to check this also along with the other investigation for these patients, because these patients are prone to have these infections, because we are going to start them on the steroids, which are going to make them immunosuppressive, and otherwise also this is an immunosuppressive state. Patients are prone to have infections in the this nephrotic syndrome. Then second line test will only be required when we are having the nephritis or atypical features. Request only if more aggressive nephritis like hypertension, macroscopic hematuria, high creatinine, and no response to corticosteroids, all the features of atypical nephrotic syndrome. Then we will say that this is, you are going to order these second line tests. And what are these? You can check that whether ASOT titer and the anti-DNS-B, these are high or not, because it will then label it as the post-streptococcal glomerulonephritis. Then ANA and the anti-DS-DNA, you can go for that